everyone, and many thanks for joining. As you know that we have the webinar on a very important topic, that is on forgetfulness and dementia, aspects of frailty, and about falls and fractures in elderly diabetics. I think these are something which we all know. And while I wait for Dr. Akash Singh, who will be chairing, uh, I would like to just say that this is an important topic, and I think everybody has come across or does come across with these problems whenever they deal with elderly patients, particularly when they deal with diabetic patients. And I'm very glad that our faculty has agreed to contribute their contribution in this webinar. So I think without any ado, we can start. In the meantime, as Dr. Akash Singh joins, he can then start conducting the proceeding, and he would, as I told him before, he would be calling one by one the esteemed faculty members, and the discussion will be towards the end for about 15 minutes. So I think I would just first like to invite Dr. Anand P. Ambali. He is professor of geriatric medicine, a highly academic person, has lots of contributions in particularly in various facets of elderly medicine, and he very kindly agreed to take up the topic of dementia, including forgetfulness in elderly diabetic. And without further any spending time, I would request Dr. Ambali, the floor is yours.
Thank you so much, sir, for this. Thank you so much, sir, for your introduction and your invitation for me. I am extremely privileged to be amongst you all, and of course of other esteemed faculty members today evening. So greetings to you all from Geriatric Clinic of Sri B.M. Patil Medical College. Am I audible, sir?
Yes, you are.
Slides are seen. Yes. Prathap, sir, slides are seen, sir. Are my slides?
Yes, audible as well as visible. You can go
Thank
ahead.
you, sir. Thank you so much. So we started our geriatric clinic way back in 2007, and now we are having 2 MD geriatric medicine seats from 2021 in the field of geriatric medicine. And apart from that, we also have a rural health scheme, immunization clinic, dementia clinic as well in our geriatric clinic. So with this background and taking the permission of chair and moderator, sir, I now discuss a few things about diabetes and dementia or forgetfulness, as Rasa rightly mentioned. So looking at the next 14 minutes, so I'll be discussing how the diabetes leads to dementia and what are the identification signs, what is the role of caregiver in this, and how to notice the behavioral changes and find the solutions for that with the take-home messages. So we all aware that diabetes is we are becoming capital of a world. So 1 million, that's the latest numbers, and so is the aging population is increasing. 149 million people in India. So diabetes per se leading to impaired cognition is on rise in older population, and this impact gives a negative impact on the quality of life of the older people. And over a period of time, once they develop full-blown dementia, their dependency level increases on the caregiver, and they develop a poor quality of life. So as far as treating diabetes is also concerned, now most of the studies have come showing some effect of some medicines, especially oral hypoglycemic drugs. They are more beneficial in preventing or delaying forgetfulness or dementia in patients with diabetes, while some drugs are known for that, which we'll discuss. And of course, any patient with diabetes now, we can delay or prevent the complication, especially the forgetfulness, as we are giving importance to the cardiac events and renal events and related to ophthalmic events. So this event should not be ignored, and that's why I think Professor Vinod sir has brought this very important topic regarding prevention of forgetfulness and how that leads to other complications in diabetes. And the most important person in treating the patients with diabetes is their family member or a caregiver, what we call, and by default, we all are caregivers for our grandparents. Now, looking at the prevalence of diabetes from the last study, which was published, I think sir was also part of this. So, what is important here is the self-reported diagnosis of diabetes among the older people is between 60 to 74 is 14.9, and more than 75 is 11. So, almost 26% of the older people among the study group are having diabetes, and most of them are in the urban areas. Now we cannot ignore this 45 to 59 people over 9 to 9.2%, because shortly they will add to the 60 to 74 range, and the longer the duration. Suppose today middle-aged man at 45 develops diabetes. At the age of 65, he is likely to develop dementia, or at the 70. So they are all the challenges in coming years. Though we cannot ignore any of these people developing diabetes at the young age, they are going to be challenge for the physician in a few decades. So the challenge, another challenge in older persons is people above 80 years. The number of people who are living 80 years and above is increasing, and they will be not only having diabetes or all non-communicable diseases, but their complications and requiring rehabilitation and palliative care. So in that, again, if they develop dementia or forgetfulness, a huge challenge for the family and the consultants. So diabetes leads to dementia, further depressions, dyslipidemia, diabetes, end organ damage, and disability. A lot of importance has been given to all the Ds, from depression to disability, but not much was talked about dementia. So we will explore how it can be assessed and what can be done in the coming years. So coming to the new concept of this optimizing brain health by WHO, they say that brain functioning across cognitive, sensory, socioeconomical, behavioral domains, allowing a person to realize their full potential of life course, irrespective of presence or absence of disorders. So that is where we as a physician strive hard. So optimizing brain health is very important because it is also an end organ. So improves mental and physical health. So creates a positive social and economic impacts, and that contributes to the overall well-being and a good quality of life among the elderly people. Now, this concept that has been brought by WHO says that looking at the age, neuroplasticity starts at the young age and diminishes as we grow old, and pruning takes place in between and it disappears. While this is very important, the midlife neuronal loss starts and proceeds with the older age, and this is where most of the non-communicable diseases take part, and even other habits also take part in this course, and they lead to dementia or forgetfulness in the older people. Even the Lancet, when it brought the risk factors for cognitive impairment, is a very beautiful picture showing what are the risk factors at each age group. So in the late life, the diabetes is one of the risk factor for developing dementia in the older people. Though it constitutes only 1%, two things are very important in this. It is mostly preventable. Mostly the progress to dementia is preventable, and if it just 1% is maybe it looks small here, but looking at the number of older people in India and people with diabetes in India, definitely this accounts to the larger number. So how diabetes leads to dementia? So diabetes per se can lead to dementia. The medicines that we use in treatment can lead to dementia. The complications of diabetes, especially hypoglycemia, can lead, and of course genetic involvement, which is we cannot divert or prevent those things. Now, looking at the dementia, whether occurs in type 1 or type 2 diabetes, most of the older people have type 2 diabetes, but we do still see type 1 in the older people. But in type 1 diabetes, the most of the slowing of mental speed takes place, and memory and learning is not affected. While in type 2, psychomotor speed, executing the functioning, and memory are largely affected over a period of time. So type people at type 2 are definitely prone for dementia. Now you look for why it is produced. A lot of factors in type 2 diabetes which leads to cognitive impairment like HbA1c. The larger the HbA1c, the the brain volume starts coming down. Resistance to insulin and hyperinsulinemia. Hypo and hyperglycemia are extensively studied, known to produce dementia. Hypertension, genetic depression, and most importantly, peripheral artery disease. If the person is with diabetes having peripheral artery disease, definitely he is bound to develop dementia as well. Now, coming to neuroplasticity, the main center for all these activities for neuroplasticity is the hippocampus, where there is a reduced neurogenesis due to diabetes, and this neurogenesis and the hippocampus impacts on the learning and the memory of the older people, and that is how the neuroplasticity doesn't work as we grow old. But can we measure neuroplasticity? No, we cannot measure neuroplasticity in live patients. If only postmortem helps to understand the hippocampal neurogenesis, whether it's taking place or not. Now, coming back to the pathophysiology, the mechanism through which hyperglycemia affects the cognitive function, it depends whether it is acute or chronic. So basically two things sets in. One is vascular pathology and second is degenerative pathology. Both combined together works in the pathogenesis of dementia in patients with diabetes. So acute hyperglycemia leads to a reduction in cerebral blood flow that results in changes in oxidative stress, and this leads to large number of reactive oxygen species, which leads to oxidation insults. And when the reactive oxygen species exceeds the antioxidant response, the neural damage occurs with subsequent functional decline. This is how pathogenesis occurs in acute stage. While in chronic hyperglycemia, there is accumulation of advanced glycation products, and this exacerbated, leading to the formation of ROS and pro-inflammatory cytokines, which again leads to microvascular damages in the brain. And not only that, it also, the advanced glycation products accelerate amyloid beta depositions and plaque formations, which further makes the elderly prone for Alzheimer's disease. Now, coming to hypoglycemia, a lot of studies have been done on the huge numbers of patients. Even one shows to almost lakhs of patients were revealed hypoglycemia associated dementia with the odds ratio of 1.5. And another study published in Diabetes Met 53,000 revealed 26% increased episode of dementia development with one episode of hypoglycemia, while 50% increase in those who have multiple or recurrent hypoglycemia. So hypoglycemia leading to cognitive decline is very, very important thing that we are dealing with. We almost every week, every month, we get one or two older patients coming with hypoglycemia. So that is how the impact is taking place. This is the another study which tells you where is the duration of diabetes anything to do with the dementia. Yes, the number of years as we pass, the risk for developing dementia is more. In this study, it was very clear that up to the 5 years of diabetes, very less people were there. And as the duration of diabetes increases, the more number of people develop dementia. So earlier, that's what I told you, that the people in between 45 to 60 now, when they develop diabetes, at the age of 70, when they come, they will be having dementia. Now, can we take this as type 2 diabetes, Alzheimer's disease? For all of us here, all of you are known that, but the audience here should know that it is still an unofficial to mention Alzheimer's to be a type 3 diabetes. But why the concept came? Because insulin plays a critical role in formation of amyloid plaques and phosphorylation of tau, which leads to neurofibril tangles. So insulin resistance leading to type 2 diabetes, and insulin is a brain leading to plaque formation. That is the probable pathogenesis that has been described. So some authors mention it as type 2 diabetes, but it is still not an official thing. Now, coming to the concept of which medicines that we use to treat diabetes can lead to cognition impairment or cognition improvement. So this is a study of one of the meta-analysis from 22 studies using 7 medicines from DPP-4, sulfonylureas, metformin, insulin, pioglitazone, and this darker thick lines tells that more number of studies have been done on these medicines, and what they found over a period of time is the medicines that are protective, oral hypoglycemic drugs that are protective are metformin, pioglitazone, and sitagliptin. They have found to improve and or delay the memory loss or dementia, while insulin is known to produce memory loss or dementia. Now, coming to knowing all this pathophysiology and all, then when to screen. When the old person comes with a history or usually from the family members that he is not able to take care of himself, okay, and without obvious reason, then suspect that some cognition impairment is there, and evidence of end organ damage like stroke or cardiac events that can even further lead to dementia, and duration of diabetes, as I've been emphasizing, history from family members of red flag sign. The old man is forgetting, some old lady forgets to off the gas stove in the home, or they misplace the things, or they wander. So many red flag signs are there, and if that comes, history is there, then we should definitely enter into the deeper examination. And all older people above 70 years with 70 years with diabetes, not of with diabetes, should undergo a screening at least once in a year. Though there are no clear-cut guidelines, but a lot of studies are telling that go for screening for dementia as we screen for albuminuria. And history of hypoglycemic episode definitely makes the older person risk for dementia. So these are the various screening tools that we use in our geriatric medicine, MMSC, MOCA. We in our clinic, we use MOCA. We are very comfortable with that. Some authors, they do Edenbrooks, and some are comfortable with MMSC. Any one of this can be used. Now coming to the last aspect, what is the impact? So knowing that diabetes is there, yes, how it happens, yes, and how dementia is going to be there, how it affects the older person. So they,
Dr. Ambani, can you wind up in next 2-3 minutes, please?
Yes, sir. Yes, sir. So what are the impacts? So difficulty recognizing the symptoms of hypoglycemia in the older person is a very negative impact on the patient's quality of life, and complications are least described or identified. So if the older person is forget to monitor glucose, then decrease frequency, give the pill box or alarms to ensure that he takes medicines. And if the patient is having problem solving difficulty, so repeated education and repeated visits has to be done. If the patient is adamant that I don't want to change and he is stubborn, refuses for new therapy, as much as possible try to avoid and don't add new things for them. And difficulty with mental flexibility, they feel anxious or regarding failing the treatment plans. So simplify regimes as much as possible and avoid insulins if it is possible in this older people. Now, the most important person I told, caregiver training. We need to train the caregiver regarding identification of red flag signs in them. Insulin dosage has to be monitored. Symptoms of hypoglycemia should be taught to them that we do, as a physician, we do that. Identification of behavior changes and pill reminder should be done. So exercise does prevents occurrence or delaying the dementia in older people by ways it improves the neuroplasticity, working memory, cognition, and those. Even WHO is giving a lot of importance for dementia risk reduction, and that is what we are doing through this program. So the take-home message is there is an multi-domain intervention in people with dementia and diabetes, because the diabetes itself is not a single entity nor the dementia. It is multiple components, and multiple team has to be worked. As much as possible, we have to avoid stringent control by AIC and avoid insulin as much as possible unless it is indicated, so that hypoglycemia should not develop. Screening for cognition should be regular in all the older people, at least those who are 70 and above. Caregiver involvement is of paramount importance. And to retain sweet memory, prevention is a key. And of course, the dementia and diabetes can, as a complication, leads to falls, fractures, and frailty, which will be discussed in detail by our next extreme speakers. So with this, I conclude and wish you all a very happy Sankranti to you all. And these are my references. And thank you for your patience.
Thank you, Dr. Ambali, for in a limited time you have touched many aspects. I was particularly impressed about the impact of dementia on diabetes with regard to the behavior and all sorts of complications, falling down, getting fractured, if you do not know about dementia in this patient. So I think very important message has been given. And now I think I would like to